We want it to be so interactive so that you will benefit from it. अगर आप समझते हैं कि जब भी स्पीकर ने बात खत्म कर ली और आप कुछ पूछना चाहते हैं, कोई भी क्वेश्चन, सिली क्वेश्चन नहीं कंसिडर होगा. Join us along with Dr. Asad Malik, who is a consultant psychiatrist and assistant professor at University of Nottingham. Dr. Amna Malik, who is a consultant, who's a gynecologist, will be joining us a bit later. And we expect that Dr. Junaid Mustafa, who is an accident and emergency consultant at Shifa International Hospital in Pakistan, will be with us shortly as well. Without any further delay, I think I'll request Dr. Asif Malik. Dr. Asif, we obviously had a chat from Dr. Noman last time, but obviously experience has gone further in the last 2 weeks as to corona epidemic is in a different form than what it was 2 weeks ago, especially with more than 600 deaths in the last 24 hours. So I'll appreciate if you can just share what do you think has evolved in the last 2 weeks and how you are managing at Queen's. And if you feel that I need to translate for the audience, then I'll do it for you.
Okay. So I think that the biggest dilemma, well, it's not really a dilemma, is that we don't know exactly what we're dealing with, and we are continuously evolving our processes, our pathways, our management. So just to kind of recap what we were doing a week ago. Well, a week ago we had single point. Patients were coming in all directions and being assessed by nursing staff wearing simple gloves or not even face masks. They were just coming in and thinking, "Oh, we think this is." Appears to be COVID. I don't know, Shamla, if you would be able to put up the pathway that I sent to you for everybody's reference at MDMI, but it's just to kind of show how we've the complexities of the pathway. That's an update that we've done, and I think that's probably the 10th or the 12th update in the last week of the flow chart of managing COVID patients. So as the volume of the number of patients coming through the front doors increases with varying severity of symptoms, we are having to manage our pathways, our processes accordingly. So each and every day there is a difference in how we manage these patients. So that was the first thing I want to kind of confirm to you in terms of the nature of what we're dealing with. The second thing has been we are seeing more and more frontline staff being due to lack of protection becoming infected and are going off frontline services. So the pressure of the workload is affecting the remaining staff. I think the first thing that you've got to establish is your frontline work staff, and not exposing people who are potentially at high risk but are working as frontline medics, nursing staff. So people who may have illnesses like diabetes or immunosuppressant medications but are working as medics, they are potentially at much higher risk of contracting COVID symptoms. So what we have advised is that those members of staff do not partake in any treatments, assessments of patients who potentially are likely to be COVID positive. On the other hand, if they are to work due to a lack of frontline staff, then the most important thing that we've established now is the role of PPE, and that's what we were talking about before. Again, for the people that are present in the room, I forwarded a paper to Shamla, who will provide that for your reference, with what we have established in our centre based on Public Health England, World Health Organization, and the anecdotal advice that's been coming out of Hong Kong, Shenzhen, Wuhan, the areas of China that were affected initially by the pandemic. And there is clearly a role for you to identify areas in your hospital. Again, forgive me, I'm not familiar with the geography of the hospital and the departments that you have, but simply having a single point of entry for all staff, for all members of the public, and having areas where you would treat COVID and non-COVID patients. That would be the first thing for us to establish. And again, forgive me if I'm teaching you how to suck eggs, but it's something that we have adapted. In being in the so-called first world centres in the UK, it's not something that came as a natural thought to us. We had to develop this COVID and non-COVID parts of the department. And so once you've established that, as I said, kind of going back to the original point, if your frontline staff need to be protected, and we were discussing personal protective equipment, and as a standard, when you're dealing with patients who are going to be going to intensive care and high dependency unit, that in itself is actually quite an easy group to manage, because those people are going to be wearing full personal protective equipment. They're going to be wearing the head gowns, the face masks, the visors, the goggles, the waterproof gowns, gloves, and covering over the footwear. It's the other patients that are perhaps undifferentiated. They may not be obvious that they have COVID. So again, on that pathway, if I could kind of point to a few areas, there is one section that we've included, because previously the guideline was if a patient has developed a cough, fever, or they've had a documented temperature at any point, they would potentially COVID. And those were the three criteria that we had. But then we soon realized after that patients may not necessarily have a cough or a fever, but they may have things like sneezing, nasal discharge, sore throat or hoarseness of the voice. They may be fatigued, general myalgia, and I think that the other kind of telling presenting complaint was delirium and new onset confusion. And in the emergency departments in the UK, the bread and butter of our patient load are elderly confused patients coming in from nursing homes or from families that are caring for them, and these patients are completely undifferentiated. So we've included that in the pathway, because a lot of staff are going in there and assessing them and providing medical care completely unprotected. So for patients who are going to be on high dependency units and intensive care, that was the guidance on the personal protective equipment. For patients who were in the non-COVID parts of the department that were potentially then subsequently deemed to be COVID, we've now introduced the same level of personal protective equipment. Now, of course, this is resource dependent, okay, on what is available to your centres. But essentially, the gown needs to be waterproof. Eye protection, face mask, and head gowns are again, you can be pragmatic and you can improvise, okay, because the aim is to protect yourself. So as long as these are waterproof, splash proof, they do not need to be expensive pieces of equipment, okay. So as a generalized heading, I've provided, surgical gowns, head covers, goggles, scarves, but these can be anything. I'm using my own personal self. I'm using cycling glasses that are waterproof as goggles, which I can disinfect in between patients if there's been splash, if there's not been any form of contamination, then I can disinfect at the end of that session. Okay, so we've gone from not having any personal protective equipment to having some personal protective equipment to now everybody having full personal protective equipment with ideas and suggestions on how to improvise that equipment set. The other thing that we've introduced is to have a contactless assessment as possible. Okay, so when I say a contactless assessment as possible, we maintain a distance of approximately 2 to 2.5 meters from the patient whilst taking a history. Okay, we've also taken out perhaps the need for an auscultation, although we may go back to reconsidering that, because what we've introduced, again, if you see the pathway, is that every patient receives a chest X-ray, because there are certain features on the chest X-ray which would indicate potential for COVID. Again, you'll have to forgive my ignorance on the capabilities at your center and whether that would be something that would be possible. So that would be a standard that would be included in every single patient's workup who was suspected COVID or there was a high degree of suspicion. And
can I just say something so that it's sort of our staff feels more relevant? All the patients coming to our facility will be from a government facility where they have been tested positive, and we are going to play the role of the surplus capacity for the government system. So some of the initial confusion about would have been hopefully done by the government, at least the diagnosis side. So from our point of view, every patient entering into the hospital would be a COVID positive patient.
Right. Okay. So then the even more relevance of the personal protective equipment and the maintaining a safe distance of communication between yourselves and the patient then would become quite relevant then.
Sure. Yes.
Thank you, Asif. I hope कि आप लोग जो बैठे हैं audience में, up till this point, would you like to ask anything? आप कुछ पूछना चाहेंगे? Asif, may I start? When you're saying that you're trying to maintain a contactless assessment, are you saying that if you know that they've got typical symptoms of corona and you would just make that judgment by inspection? I've been advised that keep your stethoscope in your pocket. I mean, we as a surgeon don't use it, but our physician colleagues are definitely keeping them in their pockets. Is that
Absolutely.
what you are practicing at
That's
Queen's?
what we're doing. Yes, that's what we're doing, because we're using the the marker is respiratory assessment, and we're kind of using the non-contact measures where you are looking at the patient in respiratory distress. Okay, if a patient is in respiratory distress and is struggling to complete, so you're kind of going back to basic medical school, are they able to complete full sentences? Is there any use of accessory muscles? Are they kind of tripoding and kind of sitting with both arms on the bed and lifting their accessory muscles and really struggling with their breathing? You can see that from the end of the bed. You can see that from approximately 2 meters away. You do not need to auscultate the chest for you to recognize that aspect of their examination. And if they are then because the mainstay of treating COVID positive patients would be to make sure that you're supporting their oxygenation, and if they are struggling with high flow oxygen or they are struggling with simple face masks, then you're going to escalate up to CPAP and potential intubations.
Can I ask a question? in
Yes, of course.
emergency department. So from a practical point of view, patients coming to our institute, then with the clinical assessment that you've guided us through, that and a chest X-ray for everyone coming in as a baseline. And
Yes.
what about in the emergency departments in UK? Are you doing blood gases on everyone, or what other parameters you're using of lab investigations?
Yeah, so all the patients, if they're not in respiratory distress. So what we're doing is when they arrive in the emergency department, we are trying first and foremost to send all of these patients back home. That's our paramount initial plan, so that they kind of come in, have they had a cough, a fever, a temperature? Yes, they are potential COVID. Do they look well? Are they tachycardic? So heart rate less than is their heart rate less than 100? Are their oxygen saturations more than 94%? And they're not in any obvious respiratory distress. We give them an information leaflet saying, look, if your symptom, essentially you're kind of working backwards. If you feel that you're starting to struggle with your breathing and you really become unwell, or family members think that you become unwell, then you must come back. So that's the first thing that we do. So that's our first kind of assessment parameter, and I think that that's something that would be an easier. It's just baseline physiological observations, which can be, and you do just need the equipment for that. Subsequent to that, if we are thinking that they need some further investigations, then yes, they all get a chest X-ray. They all get a throat swab and a nasal swab to kind of get lab confirmation that they are COVID positive. And then we do the routine bloods, full blood count, and CRP, which has been added. So if on that pathway that I sent across to Shamla, in the bottom right-hand corner, there is a whole section which we've included this week on somebody who's perhaps likely got the clinical syndrome of COVID, and they have a lymphopenia and a raised CRP. Then there is every chance that they could have COVID illness. Okay. Now there are some technicalities there. For example, CTs and CTPAs, and again, I appreciate that it's not something that may be possible in the centre that in Pakistan.
Yeah, no, we don't have a CT yet.
That's in a kind of additional guidelines, and the aim of this wasn't that this is the ultimate foolproof pathway. It was to provide some guidance, and also to show and demonstrate that the complexities of managing this illness over the past week and a half. I'm sure when I return to work on Monday that this would have changed again. Okay, and I think the most important factor that I have benefited most and foremost from is effective communication. Effective communication between staff members who are project managing the COVID pandemic, so that information is disseminated amongst all members of staff from a single point. And it kind of just goes back to the original pillars of leadership management. What we have established is a very cheap way, WhatsApp group set up, there's a single admin person from the project management team who is dealing and disseminating all of this information. It's not coming from multiple sources. There's not lots of voices. There isn't information overload from many different people. There's a single point of information hierarchy flow, and that's absolutely important as well.
I'm glad, Asif, that you mentioned that. Dr. Javed, correct me if I'm wrong, that we've already established that WhatsApp group where there is an administrator who will guide them through that. That will be the policy for the day-to-day running of the hospital during corona crisis. Is that right, Dr. Javed?
Sure. I think, and also we're almost holding daily meetings between the leadership and the Muzaffarabad team. And yes, there are two groups. One is the education group. One is the sort of admin group within this. And I think the communication certainly has improved very significantly through this corona preparatory phase.
Excellent.
If I can sort of ask you to repeat the discussion that we had while Muzaffarabad was trying to connect in terms of what we felt was appropriate PPE for different sections of ICU, HDU, and the regular ward. So I think the staff would appreciate hearing it from you.
Of course,
The
Sir,
doctor, nurses, yeah.
I would just like to add one thing. Dr. Suhail, he is a pulmonologist and intensivist. He has just joined the session. Dr. Suhail, can you raise your hand, please?
Welcome, Dr. Sohail. Thanks for joining us. Thanks for joining us.
Okay, so just to go back, so very briefly, and Farhan, tell me if I'm taking too much of everybody's time, and you want to perhaps ask the other speakers to convey their expertise.
No, please carry on.
So we briefly before we joined you, we were talking about the guidance on PPE that is provided by the agency in the United Kingdom, which is Public Health England, and in conjunction with the World Health Organization. There was clear conflict between those guidelines on PPE and what the experience of our colleagues in China. In particular, I've been in communication with Dr. Christopher Huey, who was the Deputy Chief of Service and Head of Respiratory and Critical Care Medicine at the University Hospital of Hong Kong in Shenzhen district. And I've provided a paper that we presented to our trust executive, which again Shamla will share with you, and I've sent it across for your reference. There is clear conflict between what is theoretical evidence that's been used by the Public Health England and World Health Organization, and what is the anecdotal evidence that Shenzhen, who have dealt with the pandemic and have, according to the eyes of the world, have controlled the spread of COVID in China, so that the life is able to return back to normal. So just to kind of briefly, what we're doing in the UK is social distancing, making sure that you are within 2 meters away from the person in front of you, and maintaining. So I can already see within the audience there that lots of people are sitting in close proximity to each other. So that would be the first thing that we would need to correct, where people would be sitting at least 2 meters away from each other. You're not next to each other. Okay. And we would try to maintain that whilst we're in the hospital as well, to the best of our abilities. Coming then to the PPE, we then asked our Chinese colleagues what they would classify as standard PPE for their staff. And they divided their departments into COVID, non-COVID, which I've already spoken about. So in the COVID parts of the department, there was a single point of entry, and the PPE was wearing wearing surgical scrubs with waterproof covering, and that could be, again, as I said, you could improvise on what that waterproof covering was. They used the waterproof covering that they would use in the endoscopy suite when they were performing upper GI endoscopy, but it can be anything that's waterproof. Okay, a head cover, goggles, waterproof face mask, additive face visor, along with waterproof foot covers. Okay, just to kind of give you a comparison, in London, the frontline staff that were assessing patients with COVID were only wearing aprons, mask, and gloves, and the level of sickness in their frontline staff was extremely high, where they were going off because they had contracted COVID. So they were completely unprotected. So it goes back to my first point. You know, the importance here is you have to protect yourself first and foremost, followed by the care that you're going to provide to the patient. You are just as important as the patient. Okay. And so this was the standard list of PPE equipment for patients who were being cared for in the COVID parts of the department. And we then went on to talk, we were talking very briefly about aerosol generated procedures. So this list of equipment for your personal protection was for patients who are COVID positive, who would be aerosol generating. Aerosol, things like coughing, sneezing, perhaps using a nebulizer. These would be considered as aerosol generating. Okay. And that level of equipment now has been is a standard across all the COVID parts of the department. Now, if you were to have non-COVID parts, and again, forgive me, my understanding now is that your center is going to be looking after all COVID positive patients.
That's correct. Yes.
Yes, it will be.
So in which case, then that would be the standard level of equipment that we would be recommending.
So from the summary that we discussed, for our ICU bay and our high dependency bay, the doctors and the nurses would wear the full protective gear with either FFP3 or N95 mask, goggles, the maximum protection that we can provide. We also recommended that the cleaner for that area would wear the same gear. Is that correct?
That's right, yes, because again, there is no evidence to confirm how long the aerosols remain in suspension in the atmosphere. Again, talking to the Chinese, they had identified a time frame of between half an hour to an hour that they remain suspended in the atmosphere. So we initially instituted that in the UK, where we will not clean that area until all of the aerosols have sedimented and fallen to the ground or onto the equipment, and that area was out of action for approximately an hour. Now, talking to you guys, it's obviously apparent that there needs to be a continuous turnover, and we also identify, you know, you block something for an hour, it just, everything along the line is just blocked up then. Okay, there is no patient flow through the department, and that was no longer possible. You know, it was causing an immense delay in patient assessments and potentially leaving really sick patients waiting for medical treatments. So what we then confirmed was that we can clean the area immediately as long as the cleaning staff are wearing the same level of protection.
Okay, so thank you. And so for the rest of the wards which do not have either, which is not an ICU or a high dependency unit, the staff would wear a waterproof clothing cover, gloves, regular surgical mask, and a headgear and eye protection.
That's right, yeah.
And I think we are very advantageous. I think Dr. Javed did mention it earlier on, that there will be an exhaust fan which is in each bay, which will let the air go out to an open territory outside, as compared to, we are not able to do that in for example, the setting you have at Queen's Medical Center.
No,
so
we can't
I think
do that.
That will allow us to minimize the time in between the transfer of patients. So it may not necessarily need to be an hour. It can be probably another 40 minutes or 30 minutes. Will that be right?
Yes, yes. I think that's
okay.
having the lamina.
True. In the audience, Ahmed, do we have वो हमारे पास वो है ना laboratory technician बैठे हैं? We can't hear you, Ahmed.
Yes, we do.
हाँ, तो हमारे पास जो full blood count के लिए टर्न अराउंड है वो कितनी देर में हो जाएगा? कि अगर फुल ब्लड काउंट डॉक्टर्स रिक्वेस्ट करेंगे तो कितनी देर में आप रिपोर्ट दे देंगे? जो व्हाइट सेल काउंट है जी
अर्जेंट बेस पे 15 मिनट्स और 20 मिनट्स, 15 से 20 मिनट में दे
ओके,
देंगे।
और मुझे बताएं, हमारे पास सी रिएक्टिव प्रोटीन की फैसिलिटी तो नहीं है, सीआरपी?
नहीं सर, वो नहीं है।
तो हमारे लिए आई
सीआरपी सी
थिंक
रिएक्टिव सर, स्कूबा C111 है हमारे पास, किट मंगवा लेंगे, सी रिएक्टिव प्रोटीन कर लेंगे हम, हो जाएगा।
नहीं, उसकी जरूरत नहीं है, क्योंकि जैसे डॉक्टर आसिफ ने पहले भी बताया कि अगर पेशेंट को लिम्फोपीनिया है फुल ब्लड काउंट पे, that will be another marker that they probably have got corona infection. I mean, and secondly, a chest X-ray. Asif, we have also established a pathway where we will be checking their kidney function test just to make sure that they don't have an acute kidney injury.
Yeah.
तो ऑडियंस में आप डॉक्टर साहिबान बैठी हैं, आप कुछ पूछना चाहेंगी?
Any questions from you guys?
I think while people are thinking, CRP, if we feel is appropriate, then we can ensure that we have that in Muzaffarabad in our hospital.
Yeah, it's an additional part of the pathway that we've developed, because it's a relatively easy marker that we can get here in the UK. You know, when they do the full blood count using these, and we get a CRP is a pretty standard marker, but it wasn't included in the original assessment.
Okay, well, if now there's a feeling in UK that should be part of the original assessment, and if it's feasible for us, then we would like to include that in our workup.
Secondly, for the benefit of audience, मैं आपको ये बताऊं, जैसे डॉक्टर आसिफ बता रहे थे कि जो प्रैक्टिस वो जिस तरीके से वो मरीजों को डील कर रहे थे आज से 2-3 हफ्ते पहले, डे टू डे बेसिस पे प्रैक्टिस चेंज हुई है, इनका एल्गोरिदम चेंज हुआ है. जैसे आप जो स्लाइड देख रहे हैं, आई थिंक दिस इज फ्रॉम 2nd of April, if I'm not wrong, just 2 days ago.
Yes, 2 days ago. Yeah.
They probably had at least 3 to 4 versions of this slide over the last 2 weeks. So कहने का मकसद ये है कि जैसे आप लोगों की ट्रेनिंग हो रही है, I'm sure कि जो कोलीग्स बाकी कर रहे हैं और जो वीडियोस हम देख रहे हैं, we've definitely come a long way as compared to where we were on day one. These are the crises which nobody has ever faced beforehand. So ये बड़ा reassuring है कि डॉक्टर आसिफ का भी वही एक्सपीरियंस है जो हमारा एक्सपीरियंस है over the last 2 weeks with MDMI. I'm sure कि आप लोग भी ऐसे ही फील करते हैं. Would you like to say something? ऐसा कुछ कहना चाहेंगे? आप लोग कैसा फील करते हैं कि 2 हफ्ते पहले जो आपकी सिचुएशन थी और अब आपकी जो ट्रेनिंग हुई है, do you feel better equipped, या do you feel कि अब आप you can deal with it in a better way? Anybody who would like to say something?
I think this session has been very informative in a sense that initially nobody had any idea about this pandemic and how we are going to deal with it. And especially on infection control, people were scared even to go into isolation ward setting. But with the help of your session, people are now very educated. And I think we all are in this journey together.
Excellent. That's good to know. Thank you,
if I
Asif.
could just,
that's very
just if I could just sorry, just a complete final word from me, just, and it might lead very nicely into the next speaker, because with the introduction of this effective PPE, people now feel, or medical staff, nursing staff feel that they can now, they had almost forgotten how to implement medicine. They had forgotten their assessment skills. Everybody was frozen. But now with these simple measures, people feel medicine has returned to them. Their assessment skills have returned to them. You know, they're able to diagnose and treat much better. And it's led to a much better improvement in the mental well-being of the staff. I think that might be an appropriate point for me to terminate and introduce our next speaker.
Thank you, Asif. No, I must say, and the working environment and culture has changed so much. For the benefit of audience, I'll just tell you कि जैसे हमारे हॉस्पिटल में different specialties हैं, different specialty के लोग हैं, लेकिन जब से कोरोना क्राइसिस आए हैं, सब लोग जो हैं वो मिलके ऐसे काम कर रहे हैं जैसे इट्स वन ह्यूज बिग टीम। इट डजंट मैटर कि आपकी क्या स्पेशलिटी है। हमारे कुछ सीनियर सर्जिकल ट्रेनीज हैं जो कि इंटेंसिव केयर यूनिट में चले गए हैं, ऑल्दो उनका पहले इतना एक्सपीरियंस नहीं था। सो ऐसी ऐसी सूरत में अगर आपको अपने स्किल्स को थोड़ा पॉलिश करना पड़े, या फिर जैसे अगर कोई लैब टेक्नीशियन है या रेडियोग्राफर है, वो अपना रोल थोड़ा सा चेंज करें और पेशेंट की ट्रांसपोर्टेशन में हेल्प करें, तो ऐसी सिचुएशन में आई थिंक वी आप सबको ये कुछ करना पड़ेगा, और यही सब कुछ यहाँ भी हो रहा है। आई एम श्योर आसिफ यू विल एग्री दैट everybody in accident and emergency department, you're probably seeing people from other specialties who are coming to help you as well.
Oh, of course, definitely, because we've our outpatient clinics, elective surgery theatres, etc. have all stopped. We've had rheumatologists, immunologists, orthopedic surgeons, all coming down and being part of the team. And yes, they are all outside their area of expertise. But we are managing managing them because we are effectively one team dealing with this. And if you kind of take if you take away I and me and all of that and include us and use references as our and us and the plurals, I think you find that once we come out of it on the other side, there will be lots of new relationships established, inshallah.
No, that's good to know. I think that's what the feeling is in majority of the trusts in England as well. Thank you, Asif. Thank you. Please do stay on. We may need you in between,
of course,
if
yeah.
need be, but if you have to go, thank you, Asad. Asad, I think your mic is on mute. I don't know whether you want to turn it on. Dr. Asad Malik is assistant professor at University of Nottingham. He's a consultant psychiatrist. Obviously, we have talked a lot about personal protection equipment. We have talked a lot about physical well-being. But what we have noticed during this corona epidemic, that the staff is getting under stressed. It is a bit tough time for all of us, especially for people with young families, and they have to think about a lot of other things. So Dr. Asad has kindly agreed to boost our morale in one way or the other. So over to you, Dr. Asad.
Assalamu alaikum. Could I have my slides, please? Thank you.
Is it fine now?
Yes, please. Thank you. Thank you, Farhan, for your kind introduction, and it's a pleasure to be with all of you this morning. मैं उर्दू में बात करूंगा क्योंकि I think I feel I will be able to communicate better.
No, absolutely.
Jesse Asif or Farhan and other colleagues have mentioned, it's a very challenging situation. We are in crisis, and no one in the recent history has seen such situation. और बहुत patients आ रहे हैं जिनको COVID पॉजिटिव हैं, जो सस्पेक्टेड हैं, और इसके अलावा बहुत सारे लोग हमारे आउट पेशेंट्स में ऐसे आ रहे हैं जो कि वरीड हैं कि उनको कोरोना वायरस तो नहीं हो गया, और कुछ को सिम्टम्स होते हैं जैसे खांसी, बुखार, इस तरह के सिम्टम्स होते हैं, और they think that they are suffering from and they really want to have test as soon as possible. So how do we manage those patients? Obviously, I'm not going to into details about COVID management because that's been comprehensively covered in previous talks as well as in Asif's talk. So I'll just talk about psychological or emotional well-being in this situation. So what मैंने ऐसा किया है कि मैंने मेरी जो brief talk है, I've divided into 3 parts. First thing, which is about guidance to public, because in our role as a health professional, we have the duty to guide public. उनको information देनी है कि कौन सी information जो available है on social media, on internet, is correct. The second part of my talk will be on the self-care aspect of the staff members. And the last thing which I will talk about is patients who have existing mental health problems or who presenting with new symptoms of mental illnesses, उनको हमने कैसे advice देनी है, उनको हमने कैसे manage करना है. So Shamla, could I have my third slide, please, just for, I don't know whether audience have, they can see slides, Farhan?
Ahmed, can you see the slides?
We can.
Okay, that's brilliant. Thank you. Thanks, Ahmed. तो ये जो चीज हम बात कर रहे थे, इससे थर्ड स्लाइड प्लीज. थैंक यू. तो ये हम जो बात कर रहे थे कि जो साइकोलॉजिकल वेलबींग है, तो साइकोलॉजिकल वेलबींग को डिफरेंट डिपार्टमेंट्स ने, डिपार्टमेंट ऑफ हेल्थ, पब्लिक हेल्थ इंग्लैंड और द रॉयल कॉलेजेस, एंड स्पेशली रॉयल कॉलेज ऑफ साइकियाट्रिस्ट has given special importance. So along with physical health care, they have given importance to psychological health, psychological well-being. The reasoning कि mental health और physical health दोनों linked हैं, और जिसकी physical health better होगी, उसकी mental health better होगी. Similarly, if you're looking after your psychological well-being, your mental health, your physical well-being भी बेहतर होगी. तो ये एक अदारा है, Public Health England. They have recognized this, and this is the information which is for public. Or I will not read or go through all the important all the points in slide, but what I will mention that it is important to recognize कि ये जो outbreak है, that will impact on everybody's life. So whether you are doctor, patient, nurse, driver, or you work in a shop, every person's life will be affected by this outbreak. और किस तरह लोग इसको react करते हैं, that will be different as well. Similarly, कोई भी crisis, कोई भी disaster होता है, natural disaster होता है, उसमें लोग उसको different तरीके से cope करते हैं. कुछ लोगों की coping skills better होती हैं दूसरे लोगों से, और वो उस situation में काम रहते हैं, और कुछ लोग ऐसे होते हैं जो कि बहुत अपसेट हो जाते हैं, फ्रस्ट्रेट होते हैं, और वो ऐसा फील करते हैं कि थिंग्स आर नॉट इन देयर कंट्रोल. एज वेल एज कुछ लोग होते हैं जो कि बहुत वरिड और एंग्शियस हो जाते हैं. और एक चीज जो मैंने पहले भी बात की कि लोग, बहुत सारे लोग हैं वो इस वक्त इस एंजाइटी में हैं कि उनको वायरस इन्फेक्ट कर लेगा, और a lot of people here we see they have fear of dying, कि they think about मुझे वायरस हो जाएगा और इस तरह मैं मर जाऊंगा. तो these are all the things which we have to consider. As a health professionals, we have knowledge. We know how this virus is working, how people can get this virus, how can they protect themselves. इस तरह की हम काफी सारी चीजें कर सकते हैं, लेकिन जो आम पब्लिक है उनको इसका नॉलेज नहीं है. So this is our duty to guide the public. Tell them कि किस तरह ये वायरस फैलता है, किस तरह इस वायरस को रोका जा सकता है, क्या एहतियाती तदबीर कर सकते हैं. तो that information is really important. उसके साथ साथ हमने उनकी कैसे इमोशनल वेलबींग को कैसे हमने उसको हेल्प करना है. उसकी सबसे बड़ी जो इम्पोर्टेंट बात ये है कि उनको ये इंफॉर्मेशन देनी है कि वो किस तरह अपना ख्याल रख सकते हैं. अब मोस्टली यहाँ पे जैसे इंग्लैंड में सिचुएशन है और यूके और रेस्ट ऑफ द वर्ल्ड में इट्स अ लॉकडाउन सिचुएशन. लोग अपने घरों में बैठे हुए हैं, और घर में बैठने की वजह से काफी सारी जो है ना वो फीलिंग्स डेवलप होती हैं, जैसे वो और फ्रस्ट्रेटेड होंगे, अपने जो डेली के काम काज है वो नहीं कर सकते. लोगों को इस वक्त परेशानी है कि वो कैसे अपना जरिया माश की परेशानी है कि वो कैसे अपने काम पे जा सकेंगे. काम नहीं कर सकेंगे तो वो पैसे कैसे कमाएंगे और अपने फैमिली को लुक आफ्टर कैसे करेंगे. तो ये सारी चीजें कंबाइन करके, और उसके साथ अगर इस वायरस का भी उनको एंजाइटी हो, तो दे आर नॉट गोइंग टू फील वेरी वेल अबाउट दिस सिचुएशन. तो क्या हम उनको एडवाइस कर सकते हैं, कैसे हम उनको हेल्प आउट कर सकते हैं इस सिचुएशन में. इसके अलावा जो चीज देखने वाली है कि हमने एज अ हेल्थ वर्कर हमने किस तरह अपने आप को लुक आफ्टर करना है, क्योंकि अगर हम अपने आप को लुक आफ्टर करेंगे तो वी वुड बी एबल टू लुक आफ्टर आवर पेशेंट्स बेटर, आवर फैमिलीज बेटर। तो जो चीजें बेसिक चीजें हैं वो याद रखने वाली हैं, वो इस तरह के सबसे पहले चीज जो इम्पोर्टेंट है वो ये कि हम किस तरह अपने फैमिली और अपने फ्रेंड्स के साथ कनेक्टेड रहते हैं, हम एक दूसरे को कैसे सपोर्ट कर सकते हैं, हम कैसे अपनी जो एंजाइटीज है उनको कम कर सकते हैं, हम किस तरह अपनी फिजिकल वेलबींग को लुक आफ्टर करते हैं, सम एक्सरसाइज, छोटी वॉक, इस तरह की चीजें हम कैसे कर सकते हैं, अपनी स्लीप हाइजीन का कैसे ख्याल रखते हैं। और जो इतनी सारी इंफॉर्मेशन इस वक्त अवेलेबल है, जिसमें कुछ इंफॉर्मेशन जो है वो सही है और कुछ इंफॉर्मेशन गलत है ऑन मीडिया, उसको हम कैसे डाइजेस्ट करते हैं, उसको हम कैसे अंडरस्टैंड करते हैं। तो ये सारी चीजें जो है ना, ये हमें हेल्प करेंगी कि हम अपने आप को लुक आफ्टर कर रहे हैं इन दिस सिचुएशन। अब मैं जो बात करूंगा वो शामला, could I have next slide please? Are people able to follow me so far? Are there any questions or anything so far which they want to ask?
सर मैं पीछे, जैसे आप सब लोगों को पता होगा कि वो हमारे यहाँ तो पॉलिसी है कि ड्यूरिंग कोरोना एपिडेमिक पेशेंट्स कैन नॉट हैव एनी विजिटर। नॉर्मली विजिटिंग टाइम आफ्टरनून में कपल ऑफ आवर्स होता है या फिर कपल ऑफ आवर्स इन द लेट मॉर्निंग। ऐसी सिचुएशन में जो कोरोना के मरीज हैं वो बिल्कुल अकेले होंगे, आइसोलेटेड बे में होंगे। ऑब्वियसली डॉक्टर्स, नर्सेज, पैरामेडिकल स्टाफ तो उनकी लुक आफ्टर कर रहा होगा। तो असद, वुड यू रिकमेंड के टेलीफोन पे बात करें वो मरीज to their attendants, and will that help them in their psychological well-being? I know it's not that of in terms of over here, but वहां पर जैसा सोशल सेटअप है, लोग इकट्ठे रहते हैं और फैमिली के साथ रहते हैं, तो अकेला उस बे में 4 दिन 5 दिन रहना काफी मुश्किल हो जाएगा।
बिल्कुल, ये बहुत ही इम्पोर्टेंट पॉइंट है। और मोस्ट जो हॉस्पिटल्स हैं उनमें तो विजिटिंग आवर्स तो विजिटिंग खत्म हो गई है। जैसे मेरा हॉस्पिटल है, वहां पे विजिटर्स आर नॉट अलाउड एट ऑल। तो जो रेगुलर कांटेक्ट था पेशेंट्स का अपने रिलेटिव्स के साथ, वो खत्म हो गया। तो उसको हम कैसे, उसका क्या मुतबादिल है, उसके लिए वो अपने रिलेटिव्स से फोन पे बात कर सकते हैं। और बहुत सारे फोन्स अभी जो स्मार्टफोन्स, उन पे ये सहूलत है कि वो उसको देख सकते हैं अपने रिश्तेदारों को, और रिश्तेदार भी अपने जो अजीज है जो कि हॉस्पिटल में है, वो एक दूसरे को देख सकते हैं। और ये कनेक्शन बहुत इम्पोर्टेंट है। अब इसके साथ साथ ऐसा भी है कि जो कि हमने देखा है कि जो पेशेंट्स थे वो जब अपने अजीज रिश्तेदारों के साथ बात कर रहे थे, तो वो एक दूसरे की एंजाइटीज को इंक्रीज कर रहे थे, rather than they were sharing all the bad news during that conversation, कि वो एक दूसरे की एंजाइटीज को इंक्रीज कर रहे थे। तो व्हाट वी स्टार्टेड टू डू कि हमने उन पेशेंट्स को आइडेंटिफाई किया और हमने ऐसा किया कि मेंबर ऑफ स्टाफ इज सिटिंग, एक मेंबर ऑफ स्टाफ उनके साथ बैठा होता है जो कि उस कन्वर्सेशन को उनकी पेशेंट की इजाजत से सुनता है, और बाद में उसको फैमिली को और पेशेंट को उसके बारे में बातचीत करते हैं, उनको फीडबैक देते हैं, so that from that conversation they have picked up certain things which causing anxiety to the patient. तो उससे उस पेशेंट के बाद में बात करना है कि ये जो उसके ख्याल में, उसके जहन में जो बात थी वो सही थी, वो सही नहीं थी, और उसको फैक्ट्स के साथ उस पेशेंट को हमने सेटिस्फाई करना है, ताकि वो पेशेंट जो है वो उस चीज के बारे में घबराना बंद कर दे।
असद, लेट मी ब्रिंग अनदर क्वेश्चन इस पॉइंट पे। हमारा जो प्लान था कि अभी तक ये प्लान है कि जब ये मरीज आएंगे तो हम विजिटर्स अलाउ नहीं करेंगे, लेकिन हॉस्पिटल से हर मरीज के लिए एक फोन कॉल ऑफिशियली जाएगी जो रिलेटिव्स हैं उनको अपडेट करने के लिए कि आज आपके मरीज की ये प्रोग्रेस है।
Exactly.
वो तो एक एस्पेक्ट हमने रखी थी, लेकिन आपने जो बताया है कि मरीज के पॉइंट ऑफ व्यू से वो तो फैमिली की एंजाइटी कम हो जाएगी, लेकिन मरीज की का जो सोशल कांटेक्ट टूट रहा है बाहर की दुनिया से, उसके लिए आई थिंक देन हम अपनी जब मीटिंग करेंगे जो स्टाफ के साथ, तो वी विल सी कि हम क्या प्रैक्टिकल चीज अडेप्ट कर सकते हैं कि मरीज की भी बात हो सके अपने रिलेटिव्स के साथ।
बिल्कुल।
उसमें एक चीज आपसे, एंड इफ यू डोंट वांट टू आंसर अभी स्ट्रेट, यू वांट टू थिंक अबाउट इट, हमारे पास एक रिसोर्स है जो कि हमारी ज़कात की असेसमेंट करता है, एक टीम है। Now, we know कि time of stress, religious beliefs play a very vital role आपकी psychological well-being में. तो you can either suggest now कि how can we utilize our zakat assessment staff either in communication or in some sort of counseling. They're not trained counselors, but still from a religious point of view, we can get some training for them, and then they can play a role हमारे patients की well-being में भी और maybe जो families हैं उनके भी. So if you want to think about it and come back to us, that's fine as well. But अगर कुछ suggestion अभी आपके ज़हन में है तो please share with us.
I think Javed bhai, that's a very important point. Communication, जैसे आपने कहा, two-way communication. So that is excellent news. कि जो family है, they will get an update about the relative who's in hospital. लेकिन जो आपने साथ बात की, patient उसको भी अपनी family से बात होनी चाहिए. And how can that happen? And if you have some resources who can do that, I think that will be great. और ये जो आपने बात की कि वो जो आपके पास staff है, you don't need to be qualified to do counseling. और हमारी सोसाइटी में आप देखते हैं कि बहुत सारे लोग हैं जो कि जिनकी तालीम बहुत महदूद है, but they are excellent counselors. From their experience, they've learned how to counsel people. Counsel पेशेंट्स को और फैमिली और सोसाइटी को क्या उनके रिकग्नाइज करना है कि उनकी क्या इश्यूज हैं, क्या प्रॉब्लम्स हैं उनको, और वो उनके लिए उनको हेल्प आउट करना है टू फाइंड सम सॉल्यूशंस. तो ये जो सिचुएशन है इस वक्त, इसमें हर बंदे को एंजाइटी है, और जो एंजाइटी है वो उसकी कई फॉर्म्स हैं, लेकिन उसको आप देखें तो एंजाइटी जो होती है वो एक तरह से उसको हम कहते हैं कि एक नॉर्मल एंजाइटी है, जिसमें हर बंदे को वो एक्सपीरियंस की होती है उसने एंजाइटी. उसने जैसे कोई नया काम शुरू करना है, कोई जॉब इंटरव्यू देना है या कुछ इस तरह की चीज है, तो वो एंजाइटी एक्सपीरियंस करता है. लेकिन जब वो एंजाइटी एक हद से ज्यादा बढ़ जाती है तो वो एबनॉर्मल शक्ल इख्तियार कर लेती है, जिसमें वो डिफरेंट एक्सपीरियंस करता है, सिम्टम्स, उसका पैल्पिटेशन जैसे फास्ट हार्ट बीट, उसको और तरह के जिस्मानी तकलीफ होती है, उसकी थिंकिंग ऐसे हो जाती है जिस तरह वो समझता है कि अब उसका कोई वे आउट नहीं है. तो ये सारी चीजें एबनॉर्मल फॉर्म ऑफ एंजाइटी है. तो अगर एंजाइटी जो है, अगर परेशानी जो किसी चीज की है वो अगर एक नॉर्मल लेवल में रहे तो वो प्रोडक्टिव होती है, लेकिन अगर वो उससे बाहर चली जाए तो दैट बिकम्स एबनॉर्मल और दैट बिगिंस टू इफेक्ट दैट पर्सनस लाइफ. और इस वक्त जो हम मेन चीज देख रहे हैं वो हेल्थ एंजाइटी. जो सोसाइटी में नंबर ऑफ GP colleagues call us and they talk about different patients who have known mental health problems and patients who do not have or known to have mental health problems. This health anxiety, परेशानी है उनको कि कैसे जो है ना हम इससे बच सकते हैं, और दूसरी परेशानी ये है कि they think they have the virus and they're going to die with it. So that is an extreme form of anxiety. अब उसकी ट्रीटमेंट जो है वो भी अवेलेबल है, और मैं अपने जो यहाँ पे कोलीग्स बैठे हुए हैं उनसे थोड़ी सी बात करूंगा कि क्या किया जा सकता है. जो है ना हमारे पास जो पेशेंट है जिनको एग्जिस्टिंग मेंटल हेल्थ प्रॉब्लम्स हैं, उनके बारे में उनको कैसे हम हेल्प कर सकते हैं, और जिन लोगों को मेंटल हेल्थ प्रॉब्लम्स नहीं है और वो वरीड है अबाउट और प्रेजेंटिंग विद हेल्थ एंजाइटी, उनको हम कैसे हेल्प कर सकते हैं. So Shamla, could I go to slide which says people living with severe mental illness? I think it's slide number 6 or 7.
Dr. Asad, before going to that, it's Mohsin bin Iqbal from Pakistan Red Crescent Society. I'm a psychologist, and I have been applying like psychological instruments on the normal population, specifically the literal people within Pakistan. And 21st मार्च से ऑनवर्ड मैंने एक स्टडी जो स्टार्ट की थी, दैट इज द नोशन बिहाइंड रिलीजियोसिटी कितना अफेक्ट प्ले कर रही है अब इन दिस सेटिस्फेक्शन इन लाइफ के हवाले से, स्पेसिफिकली कोविड-19 के केस के अंदर। तो जो मेरे पास तकरीबन 700 रिस्पॉन्सेज अभी तक आए हैं, उसके मुताबिक स्ट्रेस लोगों के अंदर, स्पेसिफिकली यंगस्टर्स के अंदर, जो मेरे पास एवरेज एज अभी तक लोगों की आई है, मैं अपने गूगल फॉर्म्स अराउंड जो मेरे पास मैक्सिमम लोगों ने रिप्लाई किया है, दैट आर फ्रॉम 19 टू 28 इयर्स ओल्ड, और उनमें से मैक्सिमम लोग जो थे वो अंडर ग्रेजुएट से पोस्ट ग्रेजुएट लेवल के ऊपर स्टडी कर रहे थे। लेकिन स्ट्रेस का लेवल बहुत ज्यादा इंक्रीज कर चुका है नॉर्मल पॉपुलेशन के अंदर, अकॉर्डिंग टू माय स्टडी। और साथ साथ लेकिन रिलीजियोसिटी का फैक्टर इंक्रीज कर रहा है बहुत ज्यादा। ये दोनों चीजें, तो उस चीज को कैसे हम लोग देख सकते हैं, तो जिस तरह सर जावेद ने बात की थी।
So just to make sure that I've got your question right, if you've seen more stress levels or prevalence of stress symptoms in younger population as compared to
Yes.
older population. Yes.
Yes.
And the other thing was about with regards to religious belief. Is it have you seen religion is a protective factor in this
Yes.
situation?
I have assessed through Dr. Harold G. Cohen's instrument belief in action scale, that how much time do you give to your religious beliefs, and how much do you practice religious services and all stuff. So I have assessed religiosity through that scale.
So I mean, there are certain known things which protect us from experiencing mental health problems. तो जब हम लोग किसी भी पेशेंट का जब हम अंडरस्टैंड करते हैं कि why they've developed this illness at this moment in time, so the factors we look into are biological factors. Biological factors means कि अगर किसी की जीन्स में कोई ऐसी है, मतलब फैमिली हिस्ट्री ऑफ साइकोसिस, डिप्रेशन, ये इस तरह की चीज, एंजाइटी, सो इसी तरह सोशल फैक्टर्स हैं जो कि एनवायरमेंटल फैक्टर्स हैं, and psychological factors. So ये जो religious beliefs हैं, system है, that fits in both in social factors and psychological factors. And in some, we've seen also that having a strong religious belief of any belief system, we're not talking about just Muslims or Islam.
I have included all the beliefs.
Any form of strong religious belief is seen to be protective for experiencing mental health problems, and especially in this case, well, like we've seen, there's enough evidence. People are reconnecting. People are going to their faith settings. Masjid mein, khair wo ab to masjid bhi nahi ja sakte because of the lockdown, but they're connecting means that they are more prone to pray. Or that is not only seen in Muslim population, that is seen in other population.
Yes.
These things are protective factors. और जब हम बात करते हैं कि हम अपने आप को well-being को look after कैसे कर सकते हैं, अपने patients के well-being को, so things which they find helpful, so which could be attending their religious activities. It could be something which they find it helpful, such as some reading something, mindfulness, meditation, all those things are helpful. Achha, can I just move on to what people who have existing mental health problems? I don't know if Farhan, do you see, like in your OPT at
obviously
MDMI, you have psychiatric patients?
Lots of behavioral disorders. Probably autism is very undiagnosed in our part of the world and thing, but it's good to know कि अगर आप इस ये शेयर कर सको जिन लोगों को पहले से pre-existing mental illness है, if they come with COVID-19 के उसमें वो स्पेशली क्या कर सके, that will be very helpful. Please go ahead.
Yes, I think exactly. So things which which we are aware of. Okay, people with mental health problems, they are more prone to experience anxiety and stress in this situation. एक पेशेंट है, एक बंदा है, एक पेशेंट है जिसको पहले से mental health problems हैं, and this uncertain situation is going to make him or her more anxious, obviously. तो किस तरह जो है ना वो उसको इफेक्ट कर सकते हैं. And you've highlighted very important point कि autism, intellectual disabilities and dementia, which is highly undiagnosed cases in Pakistan, awareness की वजह से, और उन लोगों को कैसे ये जो है वो information provide की जाए in situations की. And we're lucky here कि हमारे Royal College has started to develop resources for this COVID-19 coronavirus situation, resources for intellectual disability, autism, and dementia. Very simple to read, easy to understand. But what about people back home, people other parts of the world? कि उन लोगों को कैसे ये information provide की जाए? I'm happy to share those as soon as those resources are available with colleagues there at MDMI, so they can have access to. Or those resources, especially the Royal College, they provide in Urdu, other languages as well. So it's easy. क्योंकि उन लोगों को भी बताना जरूरी है कि कैसे क्या हो रहा है सारी situation. A patient with autism will not understand what's happening. जैसे हम जानते हैं कि autism में एक चीज जो patient is very finds very challenging is the change of their routine. तो एक patient autism जो कि Thursday morning को supermarket में जाता है for some reason, or he goes to some activity in day center, if they're not able to go there, it will create a lot of anxieties in them. तो किस तरह हम उनको ये information provide करें? I think at this stage, when we do not have all the written resources, it's easy to understand just basic information which we can give to the patient about what's been going on, why they are not able to access their usual care, why they're not able to go out, and how can they keep themselves safe. So I think.
Asad, can I
course.
ask a practical question? So patients who come in with a diagnosed mental health problem and are established on medication, when they come and get treated in the hospital for COVID problem,
Yes.
can they carry on with their normal medication?
Very important question, Javed bhai. Thanks for asking that question, because I was going to come to that, the treatments. So the guideline is at the moment for us is हम लोग जो medication उनकी हैं वो we will continue with those medication. I'll come to some exceptions. So we will continue the medication. The thing which we need to see, certain medications such as clozapine. Clozapine is a generic name. Pakistan में ये medication different names से available है. Clozaril is one of the main manufacturer. Novartis manufactures Clozaril. तो ये medication है. अब Clozaril के और clozapine के जो patient हैं, we know कि उनका regular blood test होता है. The reason we do blood test is to ensure their white cell count is within normal range. तो अब अगर एक पेशेंट है जो कि सस्पेक्टेड है या पॉजिटिव है, उसके अगर हम नोटिस कर रहे हैं कि उसको फीवर हो रहा है, जो कि एक वन ऑफ द कोर सिम्टम्स, उसको ऐसे साइंस ऑफ इन्फेक्शन आ रहे हैं, सो वी हैव टू check the dose of clozapine as well. So there are a number of cases. What we've done is we have reduced the dose of clozapine so that it does not have further effect on bringing their white cell count down. तो अगर एक पेशेंट जो है प्रेजेंट कर रहा है जो कि हम with symptoms of infection, we have to consider reducing the dose of clozapine. The Royal College has also been mindful of the frequency of blood test. क्योंकि जो पेशेंट है जो clozapine पे के पेशेंट है स्टार्ट में वो वीकली ब्लड टेस्ट होता है उनका, उसके बाद वो 2 वीकली पे चले जाते हैं, और जब वो ट्रीटमेंट पे सेटल हो जाते हैं आफ्टर ईयर, तो वो मंथली ब्लड टेस्ट पे होते हैं। तो वो ब्लड टेस्ट की अगर फैसिलिटीज अब अवेलेबल नहीं है या उस तरह अवेलेबल नहीं है जिस तरह पहले थी, तो देयर इज सम फ्लेक्सिबिलिटी अराउंड दैट, कि उनका ब्लड टेस्ट थोड़ा सा लेट भी हो जाए अप टू कपल ऑफ वीक्स, तो दे कैन स्टिल कंटिन्यू दैट मेडिकेशन. But we really need to make sure that they are not the clozaril or clozapine is not affecting their white cell count, which make them more prone for catching infections.
Okay, thank you, Asad. I have a request कि एक तो मुजफ्फराबाद टीम हमारा जो रेफरल फॉर्म है, we should add a separate column के ongoing psychiatric medication so that we know about any patient coming in. आपसे आसिफ रिक्वेस्ट मेरी ये है कि if we get an identified established patient, so we would need to sort of contact you and get your guidance on a day-to-day management about the psychiatric medication issue, because we cannot train all our staff, certainly not to the level of expertise that you have. And if you can spare some time, that would be of great benefit.
Inshallah, I'm available towards the end of this presentation. I've got my email address. Farhan has also got my email address and contact numbers. Happy to help as much as I can. It will be.
Of course, you have your day job as well, but thank you very much. We really appreciate that.
I just wanted to go on one more thing, if I may. Shamla, could the next slide, please? So. That's okay. So it's the slide before this, please. Yes, thank you. So some of the questions which frequently asked questions by my patient, जो पहले हम बात कर चुके हैं, और we've covered that. I can't see my family or carers face to face. How can I get in touch with them? I'm running out of my medication. What can I do? I'm on clozapine. What about blood test? These kind of questions, we are coming across quite often. Working in NHS, I think we are in a blessed situation, as well as our patients, that there are so many agencies, health agencies who are involved to make sure that patients have their regular medication, their regular test. But people back home, they will not have facilities of all these. तो मैं ये advise करूँगा कि जहाँ पे possible है, patients को should have enough supply so that they do not have this fear that they're going to run out of medication. Blood test का भी हमने discuss कर लिया, and then things which can lead to anxiety symptoms. A number of people with psychosis, they're already feeling paranoid about society. So how can we provide them information so that they feel they can trust people around them? And और last point जो है कि crisis, कि अगर कोई patient experience करता है worsening of their symptoms during this situation, what is their crisis plan? किस डॉक्टर या नर्स को जाके मिलना है, कहाँ से वो अपनी मेडिकेशन कलेक्ट करेंगे, और किस हॉस्पिटल में वो जा सकते हैं? I think that is for people who have severe mental health problem. They need to have this crisis plan so that they can, when they're feeling not well, they don't have to worry about किसके पास जाना है, कहाँ से मेडिकेशन लेनी है, और कौन से हॉस्पिटल जाना है. So these were some of my thoughts. I'm happy to take any from the audience.
असद, एक चीज, जैसे यहाँ पर पेशेंट सपोर्ट ग्रुप होता है, पेशेंट्स विद स्पेसिफिक डिजीज, दे मीट विद ईच अदर. ऑब्वियसली अब इन्फेक्शियस गाइडलाइंस को जहन में रखना है, लेकिन आपको लगता है जैसे अगर कोई यंग पेशेंट कोरोना के साथ हमारी टीम ने ट्रीट किया उसे, और वो जा रहा है, उसका स्मॉल वीडियो मैसेज जो बाकियों को दिखाया जा सके जो इन पेशेंट्स हो, डू यू थिंक दोस थिंग्स हेल्प साइकोलॉजिकली?
Of course, those things help. I mean, those are very valid point, because that shows patient that we're not talking about something which is not happened. showing videos, and that is the importance. You've seen in local media, there are news clips of patients who've recovered from coronavirus. The other day was talking about 92-year-old lady who recovered in Italy, and there was interview and video. So it helps people to know that this is actually it's not the mortality is not 100%, which means that it's not that if I have corona I'm going to die. So I think realistic picture, so that people understand that yes, people can die, but there are a number of people, a majority of people who develop this, they only have mild symptoms and they're recovering. So those videos are really helpful. Also, I think you were kind of mentioning about whether people who have, and there is a lot of evidence for that, people with self-help groups, like people who have a condition like same condition, like some form of cancer, some form of depression, some form of other physical health problem. They sit together, they share their ideas about what's helping, what's not helping with each other. And there is evidence, and we have started seeing that, like as we having today a virtual meeting, similar patients are also using different softwares to communicate to each other. They can see face to face. There's a lot of evidence, and that that helps people in providing that support, so they can set up. I know that resources are limited back home, but video message will be really helpful for people who are experiencing this condition, to hear from somebody who is being treated, who's recovered. I think will be a great morale boost for patients who are experiencing symptoms.
थैंक यू असद, थैंक यू। ऑडियंस में से आप लोग कुछ पूछना चाहेंगे?
अस्सलाम वालेकुम, मेरा कुछ सवाल है। तो फर्स्ट आप आइए इससे ग्रीप रोज को बताइए, इसमें हम मरीज को किस तरह एक स्टेज की काउंसल कर सकते हैं, थेराप्यूटिक कम्युनिकेशन के बारे में हम बता दें।
अस्सलामुअलैकुम सर।
वालेकुम सलाम।
सर ये नर्सिंग इंचार्ज है, आपसे कुछ सवाल पूछना चाह रहे हैं।
सर ये साइकोलॉजी की एक वो क्वेश्चन है सर, रोज ग्रीप साइकिल के मुताबिक जो फेस होते हैं ना पेशेंट का, इसमें हम पेशेंट की एक स्टेज की किस तरह उसका काउंसलिंग कर सकते हैं, एजुकेट कर सकते हैं सर, एक स्टेज की।
Farhan, did you get the question? Sorry,
मुझे भी आवाज शायद कुछ कट रही है। आप क्या पूछना चाह रहे हैं?
सर मेरा क्वेश्चन ये है ना कि अकॉर्डिंग टू रोज ग्रीप साइकिल जो स्टेजेस आती है, उसमें मुख्तलिफ डिफरेंट स्टेजेस है, डिनाइल, एंगर, बार्गेनिंग, एक्सेप्टेंस। उसमें हम एक स्टेजेस पे मरीज को किस तरह काउंसल कर सकते हैं, एजुकेट कर सकते हैं, थेराप्यूटिक कम्युनिकेशन के बारे में हम बता दें सर।
I think very good question. जैसे तो I think इसके लिए इस स्टेजेस से तो शायद हम सारे ही गुजर रहे हैं कि जब स्टार्ट में ये जब वायरस की न्यूज आना शुरू हुई चाइना से, तो सब लोग यही बात कर रहे थे, वी वर इन कि ये जो है वायरस इतना स्प्रेड नहीं होगा, इट वोंट बी पैंडेमिक, शायद ये एक दो और कंट्रीज में, नेबरिंग कंट्रीज में रहेगा और उससे ज्यादा नहीं स्प्रेड करेगा। So that was a denial stage for us. तो किस तरह हम काउंसल कर सकते हैं? आई थिंक जो फैक्ट्स हैं उसी से आप जो है ना वो इस चीज को डील कर सकते हैं कि जब आपके पास इंफॉर्मेशन हो, अपने आप को जो है ना एजुकेट करें फर्स्ट ऑफ ऑल कि ये वायरस क्या चीज है, कैसे स्प्रेड करता है, कैसे इससे प्रिवेंशन हो सकती है और इसकी ट्रीटमेंट क्या है। इंडिविजुअल स्टेजेस को सेपरेट करने की इतनी उसके लिए जरूरत नहीं है, क्योंकि जो आप बात कर रहे हैं वो यूजली हम ना यूज करते हैं इन bereavement काउंसलिंग। जैसे किसी की रिलेटिव या फैमिली मेंबर की डेथ हो जाए तो जो रिलेटिव्स होते हैं, जो बाकी के रिलेटिव्स होते हैं, उसके लिए हम bereavement काउंसलिंग में ये सारी स्टेजेस यूज करते हैं। उस इंडिविजुअल स्टेप हमें फॉलो करने की जरूरत नहीं, हमें सिर्फ ये बताना है लोगों को कि ये जो है फैक्ट्स देने हैं कि ये चीज जो वायरस के बारे में है, जो आपको मैंने 3-4 चीजें बताई कि कैसे स्प्रेड करता है, ये है क्या, किससे प्रिवेंशन हो सकती है और क्या ट्रीटमेंट है। जो चीज हमें उसको फर्दर लोगों को बतानी है वो ये कि उन लोगों को हमने ये बताना है कि ये जो चीज है, एंजाइटी है, फिक्रमंदी है इस वायरस के बारे में, ये इसको हम डिसमिस नहीं कर सकते। हर बंदा एक्सपीरियंस कर रहा है इसको, लेकिन कैसे हम उसको कंट्रोल कर सकते हैं, ये चीज हमने सोचनी है। कि उसके लिए क्या सिर्फ हमें जो है अपने आप को लुक आफ्टर करना, जैसे खाने पीने का ख्याल रखना, थोड़ी एक्सरसाइज करना, अपनी फैमिली के साथ कनेक्टेड रहना, उससे ठीक हो जाएगा, या इस मरीज को हमने और तरीके से ट्रीटमेंट देनी है, जैसे उसको हमें कोई दवाई शुरू करने की जरूरत है। तो हमें, मेरा ख्याल है कि हम इसको हम स्टेज बाय स्टेज नहीं हम डील कर सकते, हमें बस जो है वो पेशेंट की इंफॉर्मेशन उसको जिसे साइको एजुकेशन कहते हैं वो प्रोवाइड करनी है, और उसके बाद अगर हम देखते हैं कि वो पेशेंट जो है वो जो बातचीत करने से उसके सिम्टम्स नहीं सेटल हो रहे, देन वी मे हैव टू कंसिडर अबाउट एडिंग मेडिकेशन, ट्रीटमेंट्स भी हम स्टार्ट कर सकते हैं। और देयर नंबर ऑफ ट्रीटमेंट्स व्हिच वी कैन गिव, बायोलॉजिकल ट्रीटमेंट्स, ड्रग्स भी दे सकते हैं, मेडिकेशन आई मीन, or there is evidence of anxiolytic medication for short period of time.
Thank you, Asad. Asad, is Dr. Amna able to join us?
Just we swap our roles, and I'll ask her to come. Thank you very much.
No, you can check with her if she's able to join us for 10 minutes or so.
Okay.
Yeah, and thank you. Asad, I'm really grateful. I know you had a very busy weekend for both of you, and I'm really grateful, boss. I'm really grateful. And
if you move, sorry, Shamla, if you go to the last slide, that has got my email address. And as Javed Bhai asked, about, and this is, I'm happy if you want to share this these slides with, because the slides, one before this, please, Shamla, and we'll come to that in a minute. This has got some useful links. One slide up, yeah. So that's. डॉक्टर आसिफ भी यही बात कर रहे थे कि जो इंफॉर्मेशन है वो कहाँ से, उसका सोर्स बहुत इंपॉर्टेंट है. So rather than we read every information about coronavirus on the internet, especially WhatsApp group containing a lot of fake information, we rely on reputed websites such as NHS, WHO, and those websites, because that will help us to manage our anxieties about this. And there is a very good talk who's a friend of mine, Dr. Rais Ahmed. He's a clinical director, consultant psychiatrist in Derby. Is of YouTube on YouTube, so the link is there. So happy to share those slides with colleagues there, MDMI. And the next slide will have my email address, and I'm happy this address could be shared. And for urgent calls, I'm happy to receive phone call or WhatsApp message. That's absolutely fine.
Well, Asad, thank you very much. I think it was of great value to MDMI, and personally, I've learned a lot. Very kind of you to take time out from a very busy life, and we look forward to your contribution in future as well.
Of course, thank you. Farhan, do you want to? You're welcome.
Is Dr. Amna able to join us, or?
I'll just go and.
Please do.
Thank you.
While we are waiting to make sure that Dr. Amna can join us, in the audience, do you have any other questions, even if it is unrelated to the talks we had? कोई कुछ पूछना चाहेंगे आप?
सर ये कोविड-19 के हवाले से जो हम अपनी लैब में टेस्ट परफॉर्म करेंगे उसका मैंने एक स्ट्रक्चर बनाया है जिसमें रिकमेंडेड डेली लैब होगी जिसमें सीबीसी भी डीएमसी है और वायरल सेरोलॉजी में हेपेटाइटिस बी सेरोलॉजी, हेपेटाइटिस सी एंटीबॉडी, एचआईवी और जो रिस्क में है सीआरपी, ईएसआर और बेसलाइन ईसीजी। सर इसके अलावा कोई और हम इसमें ऐड करेंगे या आप बता सकते हैं?
To be honest with you, Asif, are you still with us or no? I think Asif has probably is probably not able to hear us. What I would say कि जो हमारा कोरोना एपिडेमिक के दौरान जो प्रोटोकॉल होगा वो मेनली फोकस्ड होगा कोरोना डायग्नोसिस और डायग्नोसिस तो हो चुका होगा, कोरोना ट्रीटमेंट से रिलेटेड होगा. आई थिंक जो आपने चीजें बताई हैं दैट विल बी इनफ. आई एम नॉट श्योर कि whether we really need hepatitis screening for every corona patient who will get admitted. Dr. Javed, do you want to shed some light on it?
I think ये जिस तरह आज CRP एक important component add हुआ है, we will keep working with our clinical group और जब हमारा पेशेंट रिसीव करने का प्लान फाइनलाइज हो जाएगा तो एक डेफिनेट हम गाइडलाइन पब्लिश करेंगे कि जब मरीज आएगा तो उसके क्या क्या टेस्ट होंगे, कौन सी एंटीबायोटिक्स हैं जिनमें से हम देंगे, एंटीफंगल क्या देंगे, बाकी चीजें क्लिनिकल गाइडलाइन हम एक अलग से बनाएंगे ताकि सबके लिए वो क्लियर हो. ब्लड टेस्ट भी उसी का पार्ट होंगे और अगर जरूरत पड़ती है तो उसको हम अपडेट या एक्सपैंड करेंगे.
डॉक्टर फरहान, ये जो viral hepatitis, of course, if it's related to COVID, it's a different matter altogether. I think doing some baseline tests is enough at the beginning. I think to do a full viral panel may be beyond our capability and cost. So I suppose we will, as Javed Bhai said, we'll have to rethink that.
True. I think कहाँ से ये आया जब हम वो लैब कोलीज वगैरह पेशेंट्स की करते हैं वहां जाके, तो आई थिंक वो हेपेटाइटिस सीरोलॉजी कम्स एज ए पैकेज विद इट. तो आई थिंक फॉर दिस कोविड क्राइसिस, until unless there is a specific need and a background of the patient with the similar disease, I think we potentially could avoid it.
Agreed.
और कुछ पूछना चाहेंगे आप लोग?
One question. So one question, I'm Dr. Sujay. Regarding N95 mask, we don't have the facility to test everybody's fitness around the face. So what's the alternative? You people have the privilege to make fit test for every healthcare profession to exactly know what is the size of the mask which is going to fit. So what's the alternative you can suggest to us in our resource limited settings? हम कैसे वो करेंगे, make sure करेंगे कि जो healthcare worker that's protected after wearing the N95 mask?
I must say, for us as an employee of the NHS, we went and we had testing for the mask as to which fits, and then they obviously will do the inhalation test and things. For you, it may not be possible. I think Dr. Zahid Sheikh had recently posted a video in the group where he has just used an ordinary sticky tape around the nose on the very first mask to prevent misting of the glasses if you are wearing the glasses. That works as a test whether air is leaking around it or you are able to inhale things. So that is something which we can use as another remedy rather than having done testing on each and every participant. Asif, would you like to say, I know we have used masks and we had testing beforehand, whether we can still smell it or whether the test is valid or not. If we don't have that facility but we do have the PPEs which are required, how do we go about it?
I think you've already you've kind of touched on it with the tape. So we've had a couple of the colleagues who've just been wearing surgical masks, and they've placed tape over their nose and across their cheeks and on the underside of the mandible over the chin to secure the face mask as best as possible. But I think it's in combination that you do, if you can improvise with a face with a visor mask as well, to prevent to kind of minimize it. Nothing is going to be 100% absolute, but I think in combination you can kind of combine things together. So wearing a mask and a facial visor, for example, would be maybe Farhan, you might be able to explain to them what a visor mask is. It's just essentially a shield in front of their face, along with the mask and the taping across the nose and across the cheeks. I think would be sufficient protection.
Now, Dr. Saab, did you get your answer, or do you think that will work out?
That's it. I got the answer.
I think it will be useful if there's a gap. वो जो डॉक्टर जाहिद की जो वीडियो है वो भी अहमद you can play या शहबाज whoever is there. अगर हमारी डिस्कशन में कोई गैप आ रहा है तो yes please.
Yes please.
Dr. Farhan, I'm going to ask the question to Dr. Asif, and if you could kindly translate the question and the answer, if I may. Okay. Dr. Asif, first of all, again, it's a real honor and it's a shame I'm not one of your colleagues, but in a way I am now.
Of course, and, my pleasure.
One of the things is you've spoken about frameworks, you've spoken about how it all comes together. We've spoken about the medical side as well. There's a support structure side as well where things have to move smoothly. How do we move from our current talking about it, practicing it, and the actual real life on the ground that you're seeing? How does that move forward?
So this is what we were talking about. There was in the first week our personal experience.
Sorry, Asif. Farhan, can you translate that so audience knows what you're talking about?
So I think as far as I could get, जो डॉक्टर इसरार कहना चाह रहे हैं कि जैसे आज से 3 हफ्ते पहले जब एपिडेमिक स्टार्ट हुआ, जैसे हमने पहले भी बात की थी कि हमारे जो सर्कमस्टांसेस थे या जितना हम प्रिपेयर्ड थे, आया आपने देखा है कि ओवर द लास्ट 2-3 वीक्स वो चीजें बदली हैं या नहीं बदली हैं, और आपने क्या गेन किया है उससे? Is that what you are trying to say, Israr bhai? Did I get it right? Sorry, I was texting Asad at the same time.
Oh, okay.
Yes, of course.
So if I may, so in our own personal experience in the first week was that the information overload. Firstly, we were hearing from lots of different channels, whether that was from our own working group, nursing groups, hospital management, external media, local media, national media, WhatsApp, Facebook. The information overload was absolutely immense. And that drove a lot of anxieties. What is going to happen to us? What are we going to do? And people lost the ability to think. I'm sure from you would have gauged from Asad's speech and comments that and his talk that anxiety, well-being, etc., are not just conditions that affect patients, but it also affects the frontline staff. So I think establishing a clear chain of command, and I think we touched on that earlier on, I can't remember at which point, was establishing a clear chain of command. When you have too many chiefs and not enough cooks, then it will lead to everybody does their own thing, and there is a clear, uncoordinated approach and management to this pandemic. I think the fundamentals of leadership management cannot be overstated in this specific situation we all find ourselves in. In this pandemic, there needs to be a clear chain of command. Information flow down the system needs to come from established leaders within your setup, and I think there needs to be a critique from those established people, and I think that's where you need, there may be some very good people on the ground level who maybe think that they are doing the right thing, and if if you all sing the same song in different tones, in different voices, eventually it all, you know, it becomes, rather than just sounding like different noises, it becomes a symphony, and everybody, it sounds like a tune, and everybody's then singing the same tune. That's the analogy. Maybe Farhan, you might be able to explain that to the audience in a better way. So I think it's just, you know, going back to the original question, it's establishing a clear chain of command, preventing information overload, and making sure you provide the relevant information to you for your setup, and keeping instructions simple, and making sure that everybody does the right thing.
Thank you, आसिफ. तो डॉक्टर आसिफ का ये एक्सपीरियंस है कि स्पेशली अभी तो आप लोग सब प्रैक्टिसिंग फेज में हैं कि हम तैयारी कर रहे हैं कि हमने कोरोना पेशेंट्स को कैसे लेना है, और यकदम जब हमारे पास 10-20 मरीज आ जाएंगे तो हम उनको कैसे मैनेज करेंगे. एट दिस स्टेज तो प्रैक्टिस है, वी आर लर्निंग, वी आर गेटिंग बेटर जैसे जैसे टाइम गुजर रहा है. लेकिन जो ही मरीज आपके पास आना शुरू होंगे तो वैसी सिचुएशन में थोड़ा सा पैनिक जरूर क्रिएट होता है. तो उसको अवॉइड करने के लिए एक तो ये बड़ा इंपॉर्टेंट है कि चेन ऑफ कमांड बड़ी डिफाइंड हो, कि जो गाइडलाइंस हमने फॉलो करनी है. जैसे मैं आपको एक एग्जांपल दूं कि हमारे हॉस्पिटल में जो हायर मैनेजमेंट है उन्होंने एक व्हाट्सएप ग्रुप बनाया हुआ है जिसमें वी आर नॉट अलाउड टू सेंड अ मैसेज, बट ओनली द 1 or 2 एडमिनिस्ट्रेटर्स आर अलाउड टू सेंड दैट मैसेज. तो हमें शायद उसी पैटर्न पे काम करना पड़ेगा. एक डेजिग्नेटेड लीड होगा उस वक्त जो ये मैसेज स्प्रेड करेगा, क्योंकि अगर बहुत सारे लोग अपने तरीके से काम करना शुरू करेंगे तो वो जो आउटपुट होगा वो नहीं होगा जो हम चाहते हैं. तो ये बड़ा इंपॉर्टेंट है कि उस वक्त हम पैनिक ना हो और चीजों को एक हाथ में रहने दें और कमांड एक हाथ में हो उस वक्त, जो हमें बताए कि आगे क्या करना है. और हम सब ने एज ए टीम काम करना है. जैसे आपको पहले बताया कि अब तो स्पेशलिटीज एग्जिस्ट ही नहीं करती. इट डजंट मैटर कि आप पीडियाट्रिशियन हो, न्यूरोसर्जन हो, जनरल सर्जन हो, जीआई सर्जन हो, everybody is working as one team. Thank you, Dr. Asif.
Thank you, Farhan. I'll just add a comment. I think जो टीम की जो तब्दीली है, ट्रांजिशन है, जो हमने देखी है जब हमने स्टार्ट किया था ये काम, और आहिस्ता आहिस्ता कुछ बीच में लोगों का वो भी था कि कोरोना के पेशेंट को देखने के लिए हमें कोई बिल्कुल आउटर स्पेस की कोई चीज क्रिएट करके काम करना पड़ेगा. ये वही मरीज हैं जो हमारे इर्द गिर्द फिर रहे हैं ऑलरेडी. और सेकंड ये है कि जो जितने ज्यादा हम इसको डिफाइन करेंगे प्रोटोकॉल से कि हमने अगर मरीज ये कर रहा है तो हमने ये करना है, ये स्टेप फॉलो करने. और तीसरी चीज जो मॉक्स जो भी हम शुरू कर रहे हैं, जो मेरा क्लीवलैंड का एक्सपीरियंस था, जो हमने अस्पताल शुरू किया था, कि हर चीज की प्रैक्टिस आप इतनी दफा कर लें मरीज के आने से पहले कि आपको स्टेप्स ना सीखने पड़ रहे हो. उस वक्त आपको ये पता हो कि मरीज अगर इस सूरत में आया है तो हमने ABC करनी है, अगर इस सूरत में आया है तो DEF करना है. तो वो हर चीज पहले से, जिसको अपनी जुबान में कहते हैं हम पका लें, तो वो हम स्टेप्स पूरे पका लें ताकि उस वक्त हमें याद ना करना पड़े कि क्या करना है. और ये हमारी, चूंकि हम उस सिचुएशन में हैं कि मरीज के आने से पहले हमारे पास वक्त है, ये सारी तैयारी हम कर लें. ये खुशकिस्मती है कि हम उस सिचुएशन में हैं और हमारे पास एक्सपर्ट्स भी हैं बाहर से जो हमें गाइड कर रहे हैं. तो इंशाल्लाह ये सारी तैयारी मिल के उस एंजाइटी को बड़ी हद तक नीचे ले आएगी.
बहुत शुक्रिया डॉक्टर जावेद. ये इट्स एब्सोल्युटली इम्पोर्टेंट कि हम सब एक पेज पे हों और वरीड ना हों और वेल प्रिपेयर्ड हों. Is Dr. Amna with us, Shamla now, or?
Dr. Farhan, I've got one doctor. Yes.
Dr. Amna. Thanks for joining us. Thanks for joining us. I'm sure
आपकी invitation का.
Okay. Just to let you know, that obviously Asad may have already fed you in के कौन-कौन लोग बैठे हैं हमारे ऑडियंस में. सामने काफी सारी लेडी डॉक्टर्स बैठी हैं. I'm sure you're able to see them. Without any further delay, because I'm aware of the timing, कि as a gynecologist, as an obstetrician, obviously आप किंग्स मिल में फेस कर रही हैं क्राइसिस. चीजें बदल गई होंगी कि आपके जो नॉर्मल एल्गोरिदम्स हैं, प्रोटोकॉल्स हैं, उनमें सिग्निफिकेंट चेंज आई होगी. तो अगर आप briefly बता सकें कि practice में कैसे change आई है, how you are dealing with pregnant ladies and everything else related to gynae, that will be really helpful. Over to you.
ठीक है, थैंक यू वेरी मच फरहान भाई. सो सबसे पहली बात है, मैंने जैसे अपनी स्लाइड्स को अरेंज किया ना, सो फर्स्ट एंड फॉरमोस्ट कि हाउ वी आर गोइंग टू प्रोवाइड केयर टू द वुमेन and their newborn babies, and then what are the risks to our pregnant healthcare professionals. So I've included a small section on that as well. So first and foremost, जो मदर को जो रिस्क इन्वॉल्व होते हैं, सबसे पहली बात है कि प्रेगनेंसी में बॉडी की जो कैपेसिटी होती है टू डील विद इन्फेक्शंस एंड इन्फ्लेमेटरी कंडीशंस रिड्यूस हो जाती है. सो इस वजह से प्रेग्नेंट वुमेन स्पेशली इन द थर्ड ट्राइमेस्टर आफ्टर 28 वीक्स ऑफ प्रेगनेंसी दे आर एट रिस्क ऑफ सिवियर डिजीज. सो ये चीज याद रखने वाली है. एंड इन द वे प्रेग्नेंट वुमेन present with concerning symptoms is also slightly different compared to general population. So mild to moderate illness is the same as in general populations, such as like cold, flu-like symptoms, you have cough and fever, but shortness of breath or other red flag signs are very, very important to identify. So I've also included a small section on the risk to baby, which is on the next slide. So there's very preliminary data to suggest that there isn't enough to suggest vertical transmission, which is transmission from mother to baby during pregnancy. जो बच्चों में जो newborns में infection हो रही है, they think most of them are actually acquired after birth. So during pregnancy, during labor, there isn't much evidence to suggest कि vertical transmission है. So there is only one reported case so far. Also, जो China से जो data available है, it hasn't suggested any increased risk of miscarriage or congenital effects on the baby if mothers acquire COVID-19 infection. So जो UK में जो changes आए हैं, which is on the next slide, antenatal care में, so इन्होंने काफी modify किया है. And they're trying to reduce the number of appointments that pregnant women are supposed to attend, either with their midwives or in the hospital. So they suggested that minimum of 6 antenatal visits. For low-risk women की जिनकी pregnancy straightforward है, कोई और जो है वो concerns नहीं है, community में ये care provide की जा सकती है. जो कि यहाँ पे UK में तो ये है कि अपने GP surgeries में एक midwife अपना clinic करती है, so they mostly attend those in those settings. लेकिन अगर कोई additional medical problems in pregnancy, so they must attend the hospital. तो उसमें इस तरह है कि हम लोगों ने जो changes introduce किए हैं कि वो जो initial जो appointments हैं, if possible, we are doing telephone consultations. और अगर patients have to attend the hospital for seeing either a midwife or an obstetrician, then try and do as much in those appointments as possible, including blood tests and scans. So with regards to the symptoms, agar the mild symptoms hai, so women should stay at home as much as possible and not attend hospital or clinics if there are no concerns with their health. Paracetamol is safe to take in pregnancy, lekin ibuprofen we usually advise to avoid. So paracetamol can be taken as recommended 4 to 6 hourly as necessary. Or general advice self-isolation key is exactly the same as for rest of the population. Agar patients ko hospital ya clinic attend karna padta hai for any reasons, so on the next slide, so they should try and attend with private transport, avoid using ambulance, because the biggest risk is situation mein hota hai of infecting other pregnant women or other people. As we all know, there is a significant risk of transmission from one person to another. So ambulance only if it's absolutely necessary. And if they do have to use an ambulance, they must inform the staff. Again, if it is possible, inform the staff before arrival to the hospital or the clinic, and the staff should also arrange for appropriate precautions, including the personal protective equipment. So, जिस तरह हम लोगों ने patients को जो है वो deal किया, so one of our staff members actually goes and receives the patient from the hospital entrance, giving them a surgical mask, and then they escort them to an isolation room. This is about the people who are symptomatic or showing symptoms. And they should stay in that isolation room for most of their care in that visit. We are trying to limit the number of people who are present in that room. For example, we have absolutely said that the midwifery students, medical students shouldn't attend those women. And we are removing, there's minimal equipment available in those rooms. Everything is available nearby, but not inside the room, as it is the case with most of the other places. And the precautions to clean those areas is the same as in line with our public health guidance. So with regards to the intrapartum care, next slide. So what we are advising our women is that early stages of labor में जब जो pains है इतनी established नहीं होती, so they should try and stay in hospital at home for as long as possible. जब hospital आ जाते हैं, then they should have hourly blood pressure, pulse, oxygen saturation, and 4-hourly temperature. The other thing to note is strict fluid balance, because usually in labor, women actually retain more fluid in their bodies. So that is why it is very, very important to have a tight balance. So with regards to mode of delivery, so it shouldn't really, if women have mild symptom, it shouldn't affect the mode of delivery. They can have vaginal delivery. However, they can become exhausted in the second stage of labor more easily than women who do not have the symptoms. So we are seriously thinking about having forceps delivery or shortening the second stage of labor for those people. However, if the condition deteriorates in labor, then an urgent delivery by cesarean section should be considered. We are highly encouraging spinal anesthesia and trying to avoid general anesthetic because of the risk to the mother and babies, but also because it's an aerosol generating procedure. So early epidural is what they're recommending here in the UK. I'm not sure whether this is the same in Pakistan or not. लेकिन ये epidural analgesia, which can be topped up if they need an urgent cesarean section, is what is the current recommendation. Even if the procedure is taking place in a spinal anesthetic, we are actually using full PPEs just because there is a small chance of conversion to a GA. So that is an important thing to note. If, however, there is elective cesarean section planned or elective induction of labor, we should try and delay this as much as possible until the women have completely recovered. The next slide is about the neonatal care. So again, if for symptomatic women, we must inform the neonatal team about the episode. Hand washing, hand hygiene, even wearing a face mask whilst handling the baby is what is currently recommended. And if the women are unwell, obviously they will need help with looking after the baby and for feeding the baby. Now, the red flag signs and symptoms that we have to look at in women who are suspected to have moderate to severe symptoms is temperature more than 38 degrees. Hypothermia is also something that we must consider. The tachycardia and tachypnea. So this is different from the adult population slightly. So in adults, general population, usually tachycardia of 100 beats per minute is not considered as a red flag sign, but it is for pregnant women. And same, more than 20 breaths per minute respiratory rate is also considered as a red flag symptom. Impaired mental state, arterial hypertension, decreased capillary refill is essentially the same with as in general population. Pregnant women generally cope really well until they suddenly deteriorate. This is what we often observe because they're young, fit and healthy, but when they deteriorate, this happens really quickly for them. And the reason, and the next slide actually also, not the next slide, so a few slides later, there is a chart which actually suggests that why these parameters are different in women, and which will come to that in a second. So with regards to who should be involved in looking after these women, so obviously so that's on the next slide. So obviously obstetrician is essential. neonatologist, especially if the baby is preterm, anesthetist, a consultant physician, and appropriately trained nursing or midwifery staff. The most important thing to note is that in an unwell patient, we must stabilize the mother first before considering delivery if there are any fetal concerns. So this is very, very important, because that's the only way to improve mother's outcomes. So never consider cesarean section for a baby who is not well if the mother is unwell, because we've had, like, this is where the disaster can happen. You can lose the mother, although you may be able to save the baby. So this is something to remember. So if you have an unwell pregnant lady who's come to us with the symptoms of COVID-19, so essentially we're following the same sepsis 6 criteria as it is for any kind of sepsis. So on the next slide, there are 6 points that we must do within an hour of presentation. So high flow oxygen, aiming to maintain 94% saturation. Blood cultures, because we shouldn't assume that all the temperature, all the women attending being unwell is due to COVID, although it is likely, but we must consider other causes as well. So for this particular reason, we are currently using IV antibiotics as well. Fluid management is essentially the same as in general population, but very careful if they are in labor, because that is when they are likely to retain more fluid. So essentially, give that in small boluses and then assess for fluid overload before giving any more. Serum lactate measurements, urine output measurements is essentially the same as for general population. So on the next slide, there are some criteria to consider if women do not respond to the initial resuscitation and when they need more input in terms of their care. Essentially, critical care or involving intensivists in their management. So this table actually shows that when is it that you must escalate. So the next slide actually shows that why the resuscitation could be difficult in pregnancy. So this actually shows, that their cardiac output is increased and therefore their circulation demands are increased. The capacity of their lungs to oxygenate also decreases because of obviously the mechanical effects of pregnancy. So there are essentially lots of different reasons why the resuscitation could be difficult. So this is why early recognition is extremely important. So on the next slide, there is a brief algorithm of this one. A brief algorithm as to how we should resuscitate if the mother becomes extremely unwell and collapses. So essentially, from more than 20 weeks onwards, all the CPR must be performed with a 15-degree tilt. So this could be either using a wedge or mechanical displacement of the uterus, so that we can relieve the pressure from the major vessels and improve the chances of success with resuscitation. Airway management is pretty challenging in pregnant women, again, because of obviously edema, which can make the intubation difficult, and therefore anesthetist it must involve a senior anesthetist essentially if it comes to that. Again, high flow oxygen as soon as possible and bag and mask ventilation until we can secure the airway. Circulation, the algorithm is exactly the same as for adults, but as I explained earlier, that all the resuscitation and the cardiac compression is to be done with a tilt. The real difference lies that if within 4 to 5 minutes of initial resuscitation, if there is no improvement, we must consider a perimortem cesarean section, because this is not for the baby, it is for improving the chances of success with the resuscitation. So perimortem cesarean section is essentially a resuscitative measure in those cases, and it should be achieved within 5 minutes of when the mother collapses. So this is all about management of women with presenting with mild, moderate to severe symptoms. Any questions so far? Because I've got the last few slides about the, how we are supposed to look after our pregnant healthcare colleagues.
Thank you, Dr. Amna. I think on practical grounds, obviously हमारे पास तो जो isolation base हमने identify की हैं, in your practice आपकी जो अगर if pregnant ladies are coming with COVID symptoms, आप उन्हें are you keeping them in separate bay individual rooms, or are they in a bay of 4? Say for example, if they are suspected COVID.
The thing is, we have made it very, very clear that they have to be in separate rooms, because agar ek jagah pe, if there are, say for example, in a setting of a labor room, if there are, let's say 10 women laboring together or admitted together, so they can infect other people. So this is why we are, so essentially this is where the capacity issues would be important, and we've got more senior staff on the floor more than ever before, just so that we can avoid unnecessary admissions, provide and divert their care to community where possible. But for the hospital, for patients requiring hospital admission, we are aiming for having them in isolated rooms.
I mean, हमारे पास थोड़े limited resources हैं. I'm sure I can see Dr. Israr will feed in, but we may be able to we may end up getting ladies who are in their early part of pregnancy, who got COVID symptom, and they're probably not aware that they are pregnant. एक वो scenario हो सकता है. मुझे नहीं लगता कि कोई third trimester की pregnant lady with COVID will be transferred to MDMI. Asrar, will that be right? Should we be feeding that into our algorithm?
I think we're not suited for any neonatal work as yet. We have 1 or 2 ventilators for neonates and pediatrics, but really we're trying to handle things on the adult side this time.
I think I would recommend if there is a senior person assessing that, whether this patient really needs admission, or how can we provide the care or the support outside the hospital if it is possible at all, because sometimes lots of people get admitted. If, like, let's say if a junior person assesses them, then they're more likely to admit patients than the decision as to.
If I may come in, because all the patients coming to MDMI would be through an agreed transfer system from the government hospitals. So in principle, we will not accept any COVID patient who is beyond 2nd trimester, so that we do not come across the dilemma of delivery. We don't have that facility at MDMI.
No, I take it. I think we should make it very clear. तो audience के लिए भी हम आपको बता दें कि जब हमने वो performa बनाया है, तो I think we need to, वो हमें absolutely make sure करना है कि we are not getting any patients who are at least in their later on in their 2nd trimester या 3rd trimester of pregnancy. I can see a lot of lady doctors sitting on the front. आप कुछ कहना चाहेंगी, पूछना चाहेंगी डॉक्टर आमना से?
सर मेरा क्वेश्चन है, मैंने आपसे पूछना है कि एक जो पॉजिटिव पेशेंट है, कोविड पॉजिटिव पेशेंट है, एंड शी इज अबाउट टू डिलीवर, तो अभी इन सर्कमस्टेंसेस में फॉर द सेफ डिलीवरी, इवन फॉर द बेबी, तो आप नॉर्मल की तरफ जाएंगे या सिजेरियन ऑप्ट करेंगे?
देखिए, इसमें मल्टीपल, मतलब once you've established that the patient herself is stable and baby's heart rate and monitoring is okay, then we should aim for normal. The reason being because cesarean section obviously is a major procedure, so this would cause additional strain on their system whilst they are still recovering from the infection. So, and we should try and avoid that and aim for normal delivery as much as possible, or at the most, forceps delivery या ताकि उनको second stage की exhaustion से जो है वो बचाया जा सके. So this is the current recommendation. Or uska ye bhi fayda hai कि they will recover quickly, they will be back to normal sooner, and they will continue their recovery at home rather than prolonging the hospital stay if they end up with a cesarean section. Obviously, if there are concerns about maternal well-being, then we shouldn't, we should do whatever is best in the interest of baby and mother.
So I have a question. Yeah, carry on.
जो बेबीज डिलीवर हो रहे हैं उनमें जो आपने देखा है कि रेशो क्या है उनमें इन्फेक्शन आने की, क्योंकि वर्टिकल ट्रांसमिशन तो साइंटिफिकली प्रूवन नहीं है अभी तक।
तो अभी तक जो है इसमें आई थिंक अप टू थ्री केसेस ऑफ, हमारे हॉस्पिटल में तो कोई भी नहीं है जिसने बेबी को हुआ हो, लेकिन up to 3 cases I think they have been reported so far, and only one of them where they are thinking there may be possible transmission. Lekin others are they're thinking that they are likely to be after delivery. So iska jo hai wo I think जैसे जैसे ये ज़्यादा होता जाएगा, we will ज़्यादा data आता जाएगा, we'll probably have clearer idea as to what the what are the chances of baby acquiring infections, but there are some where the babies have acquired it after delivery.
I've got a question about the current practice in the NHS about the staff members who are pregnant, and should they be looking after COVID patients or not?
So इसपे जो है जो Royal College of Obstetrician and Gynecologists की तरफ से काफी clear advice है. So they're saying that any pregnant women at any gestation, you should discuss with them as to whether they want to work in direct patient contact or not. And if they choose not to, then we should respect their choices. More than 28 weeks, they are recommending not to avoid direct patient contact. Less than 28, again, it's up to them if they wish to continue their patient-facing role.
Thank you.
With regards to Amina, the suspected COVID or COVID patients who are breastfeeding, उसके लिए कुछ special measures ले रहे हैं आप लोग?
इसमें जो है ये थोड़ा सा difficult area to address. The thing is, जो breastfeeding के और जो initial जो एक bonding होती है between mother and baby, इसके इतने सारे benefits हैं that they are encouraging breastfeeding as long as the appropriate precautions are taken. So they're suggesting again, hand hygiene and even wearing face mask if you're symptomatic and coughing and having to feed the baby. So you should take all the precautions. So just because of the fact that we are in very early stages of this pandemic, and we don't know the real effect of this on newborn babies, like in breastfeeding it is endless benefits and to mothers and their babies. So they're currently encouraging that mothers can breastfeed even if they are symptomatic.
Thank you.
I do have a question. So आप जो बात कर रहे थे पहले के जो isolation की, so is it I mean, if for example, if there is a pregnant lady जिसकी कोई obstetric problem नहीं है, it's mainly medical, like she's coming in because of COVID symptoms, so can she be looked after in a medical ward in the hospital or not? I mean, do you have more isolation rooms on medical wards?
I think in our hospital, what they have designed it, because this was a question specifically asked in one of the meetings, and they said normally with anybody who has got non-pregnancy related issues can go to that specialty. But during the corona epidemic, what they have suggested is that any pregnant lady who has got non-gynecological issues during this corona crisis, they will go to the gynae ward. So over there, they are putting them in an isolation room or in a bay. I'm not sure, but that's the decision they've made. That's the decision they've made.
I mean, the other thing that has happened alongside is कि जो gynecology जो elective activity that is completely cancelled. So there are no elective gynae procedures. I mean, gynae ward essentially is empty in our hospital. So that is something to look.
That's absolutely true. From our side, हमारा तो elective काम सारा रुक गया है. Bariatric surgery is fully stopped. Even for कैंसर पाथवेज हमने स्टेजिंग लैप्स जो करनी पड़ती हैं इन बिटवीन द ट्रीटमेंट मेन ट्रीटमेंट वो रोक दी हैं. द ओनली थिंग वी आर एबल टू ऑफर इज कैंसर सर्जरी, और इवन दैट टू एन एक्सटेंट के लोकल पाथवेज में चेंजेस आई हैं कि you can give them more chemo before giving them surgery. So things have changed. All the elective work is definitely stopped. And इसीलिए हमारे जो ये MDMI यूनिट है यहाँ पर हॉस्पिटल में, all the outpatient activity has been stopped. If I'm not wrong, I can see probably Mr. Iftikhar has joined. Welcome, sir. Can you hear us? Probably not. Maybe Dr. Javed or Dr. Israr can share some more.
I can hear you. I can hear you. It's just that I had shut my microphone because I didn't want to interrupt.
No. Welcome to the platform. Thanks for joining. But Dr. Amina just mentioned that all their elective work has stopped. I just wanted to ask you, when was the exact day when we stopped doing the outpatient clinics at MDMI? Was it about 3 weeks ago, if I'm not wrong?
Yes, approximately 3 weeks ago. And we also really protected everybody who was trying to come through. We shut the gates, and we were trying to screen people at the gate by looking at their temperature and all that, and symptoms. So that was good. That was good. As regard to operating and all that, we stopped all operating, not only in MDMI, as you have mentioned, Farhan. We have stopped operating here in Royal Derby as well, where I work. Complete shut off for even cancers at the moment. And as you said, these people are getting prolonged chemotherapy. So that will give us some time. Hopefully in 3-4 weeks time, things settle down a bit better. And I don't know how it will pan out in Muzaffarabad. I've got no idea. We are really not aware of how things are going.
I'm sure जो टीम बैठी है वहां पर आप लोगों ने अपने कोलीग से सुना होगा कि I'm sure मुजफ्फराबाद में भी जो इलेक्टिव वर्क है वो रुक गया है in terms of surgery. कोई बताना चाहेगा?
I think audience will be able to tell you. Some of them would know. Dr. Asif is sitting there. He's an anesthetist, and Dr. Sohail is sitting there as well, the respiratory intensivist. They would be able to tell us what's happening in Muzaffarabad in other hospitals.
All elective procedure has been Assalamualaikum, sir.
Assalamualaikum, Asif bhai. कैसे हैं आप?
All elective procedure have been stopped in Muzaffarabad. Surgical procedure and OPDs are closed. All OPDs are closed. Only emergency measures are going to be carried out.
Thank you.
मेरी तरफ से जो recommendation होगी, I think we have to seriously look into if we have a pregnant lady with only medical problems but no obstetric issues, whether we should expose the other patients in that ward as well. In my opinion, it will be better to isolate and maybe in a non gynae or obstetric area. लेकिन ये daily review जैसा हम लोग अक्सर करते हैं कि if one of our pregnant patients is admitted in a medical ward, and if we think the medical problems are more severe than the obstetric issues, then they usually have daily obstetric review by the doctors or the midwives. So if there is a provision, because the thing is, the risk would be that other pregnant women को expose कर रहे होंगे who are already a vulnerable group.
I hope कि हमारे पास इतनी ज़्यादा pregnant ladies नहीं आएंगी, because we are declared as Corona Center for this period of time. So we will make sure कि we only get limited number of them. If you end up getting them, वो उनके second or third trimester में ना हो. और Mr. Iftikhar, you will be able to tell, can we establish a guideline कि उनके लिए एक isolated bay हो, या will we be able to afford that?
Personally, I would say no, because it's not only admitting any patient, it's what you do with them as well that is important. And we don't have a gynecologist on site who could deal with the delivery processes if required cesarean section and all that. So it's a whole wide range of facility which you need to be available. have it available to deliver the care for these people. So the important thing is that if somebody tells you that there's a COVID patient, positive patient who's pregnant in third trimester, they should stay at the obstetric facility wherever there is in Muzaffarabad, and that's where they should be dealt with.
Thank you, thank you. Among the audience, आप लोग कुछ और पूछना चाहेंगे डॉक्टर आमना से? Thank you. Dr. Amna, you want to say something else on your talk, or?
Yeah, I think thank you very much again. Or अगर कभी भी कोई I'm always available. Email or.
May I say something here? Amna, being an upper GI surgeon, I enjoyed your talk tremendously. They learned a lot from it, and I hope the audience has learned as well. It was very enlightening. Thank you.
Thank you, Dr. Amna. I'm fully aware that you're too busy with your working life, and as a mother of 2 kids, and while your husband was occupied here as well for the last 2 hours, so I'm really grateful.
Thank you very much.
Thank you. Thank you. MDMI staff, would you like to ask anything? एक चीज मैं जरूर कहूंगा आपसे कि ये हमारा सेकंड वर्चुअल ट्रेनिंग सेशन था, तो इट्स वेरी इंपॉर्टेंट कि हम फेस टू फेस ट्रेनिंग तो बहुत ज्यादा करते हैं, लेकिन इट्स वेरी इंपॉर्टेंट कि वी गेट फीडबैक आपसे कि as to how you would like to run it for future, ताकि it should be mutually benefit for all of us. Any suggestions from any of you?
If I may make a suggestion, Farhan, we can our team in Muzaffarabad can have 5 minutes after we finish this course with the audience and take their suggestions and note that down, because things will be fresh in people's minds, and any suggestions they may forget later on, and then they can feed that back to you to make any changes if required.
Absolutely right. Absolutely right. Now that's why I'm reinforcing the fact that it's very important to get that feedback. So please do provide the feedback so that we can keep on improving.
I think as we move on to the next phase, there's more practical things to think about. We've been thinking more in the theoretical point of view, and the way as Dr. Javed and Dr. Iftikhar has mentioned, we need to move into more practical arena, and I think simulation is a good way of doing that. And if we can simulate and see what's happening, I think that's very, very useful. One thing I'm quite keen. Sorry, yes.
No.
Yes, and one thing I'm quite keen is just how these things will all work together, because one thing we're finding is we have to triage patients in a certain way. For example, if they need early CPAP, we know that that can be effective. So need to go to high dependency very, very quickly. So these are the processes that we need to practice and we need to understand in more detail. I think in the educational value of simulation may be the way forward.
Absolutely. I must say, when we did the first session, we did had a mock practice at that time. I think Dr. Adil was there, and we did practice lots of things. It's just that the mixture of talks today was in a way that doing all the practical skill stations would not have been possible with the psychiatrist being on the panel, as well as maybe a pregnant lady scenario could have been done. But no, that's something we will carry on. We did it in the first session, and we'll try to do it in the third session as well. Thank you. If there is no question from MDMI, Shamla, I'm happy for you to disconnect MDMI, then we can have a brief among ourselves.
Yes, Farhan, just let me thank Farhan for organizing this wonderful scientific session, getting all those skilled, busy people available and engaged for this meeting, and supervising and conducting the course overall. Thank you so much, Farhan, and we really appreciate your input into this important activity.
I'm grateful that you're all taking part. Thank you.
And thank you to the audience for staying and listening and paying attention, asking all the questions. Thank you.
I'm sorry to interrupt, Dr. Javed. I think the NDMI team had requested me to play the video while we are still in session. So the video is of Dr. Zahid, I think, demonstrating about the PPE.
Please do.
Yeah,
Please.
if you play that, and we'll say goodbye now.
All right. Okay,
Okay.
I shall play that. Yeah.
Thank you.
Thank you.
Thank you, everybody.
आप इसको सही करें ना कि हमें टेबल अंदर
जाहिद जो है स्लो मोशन में डेमोन्स्ट्रेट कर रहा है.
It's a good video, boss. Easy.
It's a good video. It's a good video. At least they
very valid point.
जो टेप जो लगाया ना चारों तरफ से.
Hospital software system.
Everything seems to have stopped.
Yeah, it looks like it.
May I suggest that they can download it themselves onto their lecture one, and they can do it themselves, and we can move on.
Yeah.
Can you hear me?
Yes, we can.
You can hear you.
Oh, okay. So I think the MDMI team has left.
Okay, that's fine. I can still see them. If you are you able to disconnect them?
They're still on.
Okay, they're still
Ahmad, can
on.
you disconnect, please?
Ahmad, thank you very much. Will you be able to disconnect from your end?
Yeah, I'll ask him. I'll ask him on WhatsApp. Just a sec.
I think they've gone.
Yeah.
Thanks. They've gone, have they? Asad, Asad, are you with me?
Yes, I am. Assalamu alaikum.
Asad, बहुत शुक्रिया यार, बहुत शुक्रिया. I'm really sorry. I know you had a busy morning, both you and Amna, but really grateful, really grateful. Dr. Israr?
Dr. Farhan Ji.
Ji, I totally take your point. जो practical mock stations हैं, like we did on the very first session. But the second session, the mixture of talk was like this. It's very difficult to engage in any practical station related to psychological well-being, or maybe for gynae we should have done it. Maybe for gynae we should have done it. But for the next,
it was just saying about the future as the group is moving forward. But I think this is an amazing session, really amazing.
Yeah, Farhan, I came a bit late, but listen to.